move toward the session 2 of the day. So let me invite Miss Ekta Modi, COO, Parul Sevashram Hospital, Dr. Rupali Basu, Managing Director and CEO, Woodlands Multispeciality Hospital Limited, Dr. R.V.Karanjekar, CEO, Kiran Multisuper Speciality Hospital, Mr. Yateesh Wahaal, Executive Director, Nayati Healthcare and Research, New Delhi, Dr. Venkat Ramana Sudigali, Director and CEO of Excell Hospitals, Hyderabad, Telangana, Mr. Devanand KT, Regional CEO, Aster DM Healthcare, Hyderabad. And Mr. Devanand is also the moderator of the session. So we welcome you all. It's over to you, Mr. Devanand.
Hi, thank you, Shyam. Hope I am audible.
Yes, sir.
Yeah, thank you so much. Thank you so much, ArdorComm and Mr. Chandan and the team for inviting all of us. I'm really excited today to be here among all of you for two reasons. One, it's a very fantastic panel that I have to moderate. You know, very distinguished and accomplished panelists that we have today who will be speaking on a very important subject, which is the rural-urban healthcare divide. So that's a very interesting subject. You know, usually you don't hear this subject being discussed much in any of the panels. So I'm really excited to be here. And are you planning to give an introduction of the other panelists, and then you want to start? How is it going to be? Yeah, Yateesh. Hello, I think Chandan, you are on mute.
Sir, you can start the session and let the panelists join in between.
Okay. So I'll start myself. So I'll just introduce myself and then I'll start with the first panelist so that they can also tell something about themselves, and then we can go with the flow. So I'm Devanand. I'm the Regional CEO of Aster DM Healthcare, covering the Andhra Telangana cluster. I handle 5 hospitals in this cluster. So I'm with Aster for the last 13 years. I was in Kerala and then moved to Hyderabad subsequently in 2019. So it gives me extremely, it's a happy occasion for me to moderate the panel for two reasons I mentioned earlier. So without much delay, because we have a time constraint also here. So I go to the first panelist, who's the Chief Operating Officer of the hospital, Parul Sevashram Hospital, Ms. Ekta Modi. So who is going to probably give us her insights on the first thing, which is the first and foremost thing to start the discussion, which is what, according to you, Ms. Ekta, is there a health divide? First of all, that's what we want to know, right? From before we start into this very interesting topic. So, is there a healthcare divide among the rural-urban class, and what are the factors do you think are creating this real healthcare divide among the urban and rural class?
Thank you, Mr. Ray. Good afternoon to everyone, this senior panelists and actors. So, telling about myself, I represent Parul Sevashram Hospital, which is a teaching hospital for Wahaal Institute of Medical Sciences and Research. We are a teaching hospital for undergraduates and postgraduates now. So, yes, we are.
Sorry to interrupt. Please be a little clear or bring your mic to your near mouth so that we can listen properly. Sorry.
Sorry. Now it's better. Hello?
Yeah, it's better. We can hear properly.
Better. I think your microphone, if it is closer to your mouth, it'll be more.
Yeah.
Thank you.
I think I'm the speaker now. So we are a teaching hospital for undergraduates and postgraduates, and we are presently in a rural area of Hyderabad, that is Basu. So yes, the very important thing which Mr. Dev brought in was factors impacting the urban-rural healthcare divide. So yes, it's a divide because there are a lot of factors which influence and affect this, like the health awareness, which is very important when we speak about the divide. So the rural people, we used to think that they are not that much aware about the health benefits they should seek or health schemes they should have. But thankfully, COVID has brought up so much awareness, even in the rural sector, that now they are also aware, they are also informed. So the gap is bridging in some of the factors, but the awareness still needs to be more in the rural areas. The level of education is also an important factor, which is impacting the urban-rural healthcare facilities. The economic status of the families or the patients coming from rural areas impact the health benefits. And most importantly, the availability of healthcare. So if the availability of healthcare is not like it's very rare, then they are not focused to the needs they have, or if we say the preventive healthcare aspect, which we find more in the more in the urban areas, it's not that prominent in the rural areas. They visit the hospital only if it's a dire emergency or if they need to. Otherwise, when we talk about the urban sector, we all know that the preventive health checkup is like booming. But now, even in rural areas, we are going in their cities. So the remote areas are now dealt very well with the available infrastructure, which I'll be talking in my next version. So yes, the outreach needs to be strengthened, and like there is less use of the certain health informatics which they have. Then there is decreased preventive health checkup, which we spoke about. Health literacy, which we are planning to a lot of sessions. We are engaging the ASHA workers and everyone who are they are the key people for the rural areas whom they look up for their health benefits. They reach out to the ASHA worker only if they have any health benefits. So educating the health are following in rural areas. We are strengthening the structural barriers, like there is a shortage of super specialist doctors in a certain rural area. So we are now developing certain e kiosks, deliverables, which act as a boon to the rural areas. So I think even financing the health sector is a long-standing challenge, because the rural areas are not that economically. So I think we need to use all the available channels which we have to close this rural and urban gap, and promote best practices, like using the holistic healthcare model, which is now a need of the hour to reach the rural population.
Thank you so much, Ms. Ekta. Very, very elaborate, and so I could understand that the awareness, the accessibility, and also the shortage of manpower. These are the few things that really came up from your point. So there, you are seeing that, yes, of course, there is a divide among the urban and rural healthcare. So and there are ways in which that can be addressed also. But with the new budget, recently unveiled by our health finance minister, we know that there is a huge impact that's going to happen on the e-health or the digital health that we see in India. Especially, there is a targeted focus towards implementing those digital things across India, which will cover the rural side also. So we have the next panelist. I would like to get his insights on this particular aspect, where India is also focusing on the digital health across the country. So that will definitely focus on the rural areas also. So how do you think Dr. Karanjekar, who is our next panelist, who is the CEO of Kiran Multispeciality Hospital, who is a veteran in healthcare. So how do you think, Dr. Karanjekar, how can we solve this lack of e-health services in rural India, where India is a country where we are looking towards a digital health adoption?
You can speak from the device speaker, sir. Kindly plug out the.
He has done that. Yeah. No, you can please check your system. By the time I'll go to the next panelist and come back to you, sir. Yeah, so I think that question will come back to him again, because that's something which I wanted his inputs, because he's as a veteran, healthcare veteran. So we would like to hear from him on that particular aspect. So now we'll go to Dr. Rupali Basu, who is another very accomplished healthcare leader, who has been also covering Apollo, and I think you were covering the eastern side of India, which was a neglected area, right? So long back, probably, yes, but then you will definitely have that kind of experience covering that area, which had huge dearth of healthcare facilities. So what do you think? What is the impact? You know, lot of new things have come in. We have seen the power of telehealth in terms of COVID app when the vaccination drive came up. So a lot of technology is being used in bridging the gap of urban-rural health divide. So what do you think has medical technology has impacted, whether it has impacted on the urban healthcare divide?
Thanks, Dev. And thank you, ArdorComm, Media, Chandan, and Ayush, all of you who kept on talking to us and having us in the panel. It's not so easy to make such a big, new normal healthcare leadership summit. And of course, you've added awards to it also. So kudos to all of you. Only thing is that this, we need to get out of this online thingies and, get on into in person. And it's high time now that we need to be in person and seeing each other. That's always make a lot of difference. Coming to the discussion point, I think you of course did mention about the East. So I've been trained all over the world, traveled all over the world, but focused at work at the East, because yes, I thought that at that time, which was probably 35 years back, 3 decades back, there was the healthcare delivery systems in the East where need to be, kind of worked on. The quality journeys needed to be brought in. The bigger hospitals needed to be developed from the background of the first open heart cardiac surgery. First open heart surgery happened in PG Hospital in Calcutta. For the whole country, you all should know, in 1957, my father-in-law, Professor Dr. Ajit Kumar Basu, did the first open heart surgery in Calcutta. And that was years back. So the first cardiothoracic surgery department happened there. And Baba, of course, was very, very renowned as a cardiac surgeon, scientist, academician, and have worked all over the country and all over the world. He still is the only Indian who wrote a chapter in our textbook of surgery called Love and Bailey's. And of course, he was an FRCS examiner on all that. But that's, he's gone from this world in 1986. And that years back, we did fall out in between. And naturally, we needed to be having leadership and thoughts and the right kind of work at the region. After all, it is 300 million people who resides in the eastern part of the country. And when we talk about the rural-urban divide, as you asked Ekta, I was just thinking that countries, we have just heard that we crossed China's population. I think we have now become the most populous country in the world, the largest democracy. Of course, if we were, I think we have touched 1.4 billion now. And 70% of that population, which is almost close to 900 million or 90 crores, lives in the rural areas. And definitely for all our good things that we have done at the private hospitals, at the levels of our corporate hospitals, we keep reaching to the best possible benchmarks in the world, the international benchmarks. And that's what we have done, we are doing. We are very, very close to whatever is the most advanced quaternary care happening in the world. We are touching there. Almost, may not be the level of research or academics which should happen at those levels, may not be at that same level. But what we do is whatever is happening in the US or Europe or anywhere good, we are picking it up very fast. So our level of care is good. But is it happening for everyone in this country? Is it available for everyone in our country? I don't think we have yet reached to every Indian of that level of care. And that brings us to technology. Technology is an enabler. I think it is a big enabler, big helping tool for us to reach that divide between an urban and rural healthcare delivery systems. And what are the things, I have, as you said, I have served Apollo for 15 long years as president and CEO. I've been, with Dr. Karanjekar, who was my colleague in Woodlands hospitals, which has become Fortis now, for 7 long years, handling Eastern region. And of course, I've been now considered as a turnaround specialist who kind of handle turnarounds of hospitals. So I am right now working in Woodlands Hospital. It's a one hospital company of the 45,000 people involved in our PSG group. It's a very large group with 30 companies. And whatever, I think 30,000 crores top line or whatever. So we are one of those big industry groups, and this is the only hospital the group has. So, and we are bringing in new, advancements in the hospital. So I am entrusted with that job. But we see the healthcare delivery happening in the cities and in our villages, and the gap is we started talking about technology and how it will be a bridge between the rural urban divide years back, because we know the gaps that have been talked about already. The difficulties were because we didn't have the right connectivity, the right kind of smart devices, and the right kind of smart devices in both in computers or phones. So the moment those things are available now, we have good connectivity to the remotest villages of our country, and we do have smartphones. Now, availability of smartphones to everyone, I don't know whether that is yet happened, but I'm sure it is going to happen. So very soon, and very large number of people actually do have smartphones. Why I'm talking about smartphones and computer systems? Because the tools that we have now, the teleradiology or the EICU or the teleconsultation, or even reading out your talking about giving the care from the specialist to at a long distance, you need to have those technological specs ready so that you are actually able to give those care at a distance. And the availability of the specialist are, what is an EICU? We have started EICU 15 years back in Apollo, but we were not been able to do that quality care at that time. That 100% of, yes, I've been able to give the quality of ICU care which I'm giving in the city of Calcutta or Delhi or Mumbai, and giving the same quality of care in any part of our networked rural areas. But that's what I think now is possible. And COVID has also shown us that you can bridge, you can do protocolized care, you can do standardized treatment guideline, you can actually reach to the remotest corners through technology. And I will close my talk here, because there are others who will listen to everyone. But I think it is time that technology is, as an enabler, is ready and is a success in many areas. We just need to do that little bit to reach everywhere. Thank you, Dev, once again.
Thank you, Dr. Basu. So, Dr. Karanjekar, I hope your audio is now correct. So, but you can actually start from where Dr. Basu stopped, actually. So, this again comes back to the lack of e-health services in rural India. So, that's what we expected you to respond, Doctor. Over to you.
Dr. Karanjekar is joined through the phone.
Yeah, I joined through the mobile.
Yeah. Very good. Now it's perfect. Loud and clear. Yeah. So I think I'll then give it back to you again, Dr. Kiran.
Okay, sure.
Eager to hear you.
No, now you can hear me. Is it?
Yes.
Yeah. Okay, sure. Thank you, Devanand, Rupali, and all other colleagues. Adore communication also. I think the question posed to me regarding the e-health in rural area and its impact, or how do we do it? When I look at all 40 years going into the rural areas in Himachal Pradesh, also in Chennai, also in Gujarat, I feel 65% of the population which is staying into the rural area is still deprived of lot of health treatment. Health treatment is also, I divided into 2 or 3 parts, because today we are talking of corona, today we are talking of so many things. But when it comes to the serious diseases, surgical work or emergencies, the telemedicine becomes little handicapped. To me, 3 major things are required when you are looking at the rural health. These are the 3 A's. One is the acceptability, another is the awareness, and third is the accessibility. Accessibility is the most important one. However great equipment or modality I have, but if I can't reach to the place, then it will be of no use for me to reach. And today, if I see, I go to the Konkan area, I go to the down south in Maharashtra or even in Marathwada area, the moment you land in around, there is no network. Even for the simple phone, you don't have network. Carrying out the images from CTMR, carrying out the ECGs, carrying out some of the primary investigation, it is becoming difficult at various places. Second is the acceptability. Indian people, especially the rural people, want to see the face of doctor. And if they see it in the camera, still not, they have not accepted it. Because apart from meeting the doctor on camera, making online payments and seeing what has happened, and there is nobody around you, it becomes very difficult. So a medical personnel at every place is very important. If that personnel is there, coordinating between the consultant and the patient, it becomes much easier. And third is that once you have accessibility, you have then you accept the whole thing and make the people aware, because this is the modality. And very rightly Rupali said that Corona has made it awareness so huge that probably, as we say that the vaccines take 10 years to develop and we developed in 1 year. Similarly, I remember our JCI days and NABH days, we were trying so hard for hand washing, and every time we are failing. Last 20% people were not washing hand at all. But with Corona in background, everybody, even the person coming to the door, delivering anything, you touch it and you wash the hand. So that kind of awareness has come into the people. If the similar awareness comes for the e-health treatment, that will be better. I tell you, about 15 or 20 years back, it is nothing new. It is only the implementation of the whole thing. I had gone to a very rural area in Adivasi area in Devdaman and near Silvassa, where small wadis are there. 100 people stay. And from there, from camera, they were picking the patient's health indicators on a camera, giving it to the civil hospital, doctor sitting there, monitoring it and advising them. Even though it was preliminary, they were helping thousands and thousands of Adivasi people. It is not difficult, but you have to reach them. And your probably internet, 4G, 5G, whatever it has to reach that place. Once that is there, then people will be aware, people will accept it. This is the first step of the whole thing. The second step is that once they accept, you will have to deliver. If somebody is serious on this thing, then you will need a road, transportation, ambulances, and the nearest medical help. So probably government will have to think of hub and spoke models, where the main centers are there at taluka place or district place, from where you can go to the rural place, do it, because again, time is an important factor. So these cases, if happen, see, today we are progressing. Today we are in the middle. I can't say कि अभी खिचड़ी पक गई है, but अभी चावल भी नहीं है. It is in between stage. Same stage is also for our connectivity. Same stage is for transportation. Same stage is for our awareness. People are aware about mobile working, everything. Similarly, they will be aware of the healthcare needs and healthcare indicators. Once we get that, we will start helping them. The success is in proving to them that this can happen. Once we prove it to them, this can happen, they will be after you. So, yes, it's a slow, steady progress. Earlier we do it, we should be successful in this, because we are talking of some 65 to 70% of the population. Pardon me, but today I was thinking that there will be at least 1 or 2 panelists who are from the remote rural area and who have experienced this thing. Probably their words would not have appeared hollow as our words happen, because we are all the time in the city, corporate hospital, big hospital, where every facility at the beck of call, we have it. But rural, you have to see actually what it is, and their experience would have taught us something. But yes, definitely we can learn from them, visit them and do something.
Thank you, sir. Thank you so much for that wonderful, hands-on experience, the insights from the hands-on experience that you have. Thank you so much for that insights. Actually speaking, even though I represent Aster, I did not mention that I worked in a remote area for 10 years, which is the most backward district of India. It's called Wayanad in Kerala, which is basically one of the most dispersed districts also as per the Niti Aayog. So we also run a medical college there. The basic purpose of our chairman was to start something there, which was totally lacking in terms of medical facility, in terms of rural divide. We worked with 18% rural population with included tribals. 18% were tribals actually. So it was very challenging, but I thought this is a forum where the panelists should say, so that's why I did not mention about it in the beginning. But towards the end, probably I can also share a bit of the experience that I had there. So I'll take the question to Mr. Yateesh. I think we had made a beginning, but I think some connectivity issue he had to log out. So Mr. Yateesh, now we all agree that healthcare technology has become an enabler for healthcare. No doubt about it. We all have to adopt that. So how much influence is there on the funding for this to get really getting adopted across?
Well, Dave, thank you for ArdorComm to having invited us over for this panel and for taking this discussion, which is need of the hour. See, the pandemic virtually forced all of us to evolve and adapt to the technological advancements that were taking place. Unfortunately, with the pandemic normalized, we are back to normal times. And I think the teleconsults, as is visible in our hospital, I think the fellow panelists would also agree, though definitely the numbers have improved than what they were pre-pandemic levels, but they've reduced drastically, because as Dr. Karanjekar was also mentioning, at the end of the day, see, adaptation takes time, and people are yet to adapt to the fact that, there's no doctor physically touching them and, taking their parameters or having a face-to-face conversation. So this process at the end of the patient has to evolve. And at the other end, even from a clinician's perspective, moving on and transitioning to a totally EMR-based environment is something that, again, the present constraint of the pandemic assisted us. But still the senior doctors, those, there are exceptions everywhere, but you can't expect them to change overnight. So whilst the fresh breed, the fresh crop is adapting to it, and people on the floor are the ones who are getting into EMR, some of the senior doctors are still not very comfortable with the EMR part. Having said so, the core question that was posed to me in terms of capital funding and how that is an influencer in terms of the adaptation, see, capital plays a very important role. And one of the reasons the urban-rural healthcare divide has also been around is because healthcare intrinsically is a very capitally intensive industry. And IT, unfortunately, till a few years ago, never played a very important part. And it was always supposed to be a cost center. Now, with time, it has become a strategic cost center, wherein one is starting to see that if you were to digitize records, in addition to patient convenience and access, what that is also resulting into is additional revenue. E-pharmacy, if you are able to map your EMR into pharmacy, into diagnostic, if you know what your doctor has prescribed, the administrator or the front office at the end of the day, or the department at the end of the day, is able to check its conversions. See, till everything is linked with revenue, it really doesn't work out. So that somewhere has helped as administrators also not to get our bosses, the directors and the funders or the trustees, to see value and introduce this. Having said so, again, because the number of adapters are still limited in the market, the cost of introducing this technology, the cost of introducing this hardware is huge. And for a small rural-based setup or a non-metro-based setup or a metro-based setup with just a single unit and not a chain, they may find a capital allocation to be slightly difficult. And therefore, this problem has to be assessed in totality. If you were to today again spur entrepreneurship in this, and there are solutions that have come about, And one of them being that the market, knowing that money cannot be brought in overnight, and even if you were to bring in soft capital, today rate of interest is still not below 8-9% for an average borrower. For someone with a A+ rating, maybe it will be about 6.5-7%. But the repayment starts, there's not enough moratorium. Unlike some of the, for that matter, even Bangkok per se, or Thailand, wherein you have repayment periods, or Indonesia, where you have repayment tenures going up to 20-25 years. Because healthcare, and this is one of the need that all healthcare players have stressed to the Honorable FM also, wherein we are saying give this infrastructure status and give them a longer term funding tenure, so anywhere between 15 years to 25 years, so that there is enough cushion available for healthcare players to recoup the investment made. Now, one of the ways technologically based Indian entrepreneurs have started to solve the problem of technology adaptation is they have brought in a model of pay-per-use. Instead of and somewhere using the power of cloud computing and cloud servers. So, see, there were two constraints. One is you need to have heavy servers for backing up all your files and having a redundancy in your network. The second bit was your network issue. Fortunately, with the likes of Jio coming in and 4G and 5G being made available, this problem has been addressed, as Rupali was also mentioning, Dr. Basu, that now with smartphones coming in, it's getting addressed. But somewhere Indian entrepreneurs had even sorted this out, wherein in India, the sort of products that offer these services are more built on a 2G based platform as opposed to a 4G, 5G, so that even where in areas, remote areas where data proves to be a challenge, there is still a probability, albeit with a longer delay, of sharing the data packets across. So with cloud computing and hosting your servers on the cloud, somewhere like a Google or a Amazon-based server farm, you are able to pay this and on an OPEX-based model and not a CAPEX model. Likewise, you have players who've now come in and they are charging on EMR on a per patient basis or a per visit basis, as opposed to just selling the entire show in one go and blocking a huge amount of CAPEX and then going in for an EMC, CMC. So, wherever there is a constraint, history has it that, constraint leads to inventions, and Indians, all of us, are far, far ahead when it comes to the road of invention. AI, for instance, a lot of local players, tele-reporting players, and even some of us at the corporate hospitals, the teams had standardized protocols wherein just after a scan, basis the pattern that had developed in the lungs, one was able to tell whether there was a COVID case or a non-COVID case, and one really didn't have to wait for the reporting to happen. So, AI and technology definitely is here to help. Cost obviously has been a concern, but with the metros really reaching a sort of a saturation and local partners coming up, you have all major chains which have, at least for now, if not really gone into the rural areas, they've started opening centers at least in state capitals. So the presence has started, because this movement of going to the metro for treatment is stopping. And the core problem, again, still today that stays there is that given the very size of the country, which in itself is the opportunity, we do not have the number of healthcare practitioners to cater to that entire demand. And thus, using technology, we can get in these skill sets that are available with the metro-based setups, maybe within the corporate setups, available to the last chain, available within that corporate center.
Yes, Mr. Yateesh, yes, thank you. Thank you so much for that. I think
Thanks,
the paper use, the OPEX model of technology coming in can really help us in getting it implemented across rural and where the capex or the capital investment can significantly come down. So that's a very, very valid point. I think a lot of people have already started experimenting on that. That takes me to the next question to Dr. Venkat, who's our next panelist. whom I know that he has started teleradiology at a much earlier stage than all of us started doing at our hospital. So Dr. Venkat, I think you are the one who probably you are the front runners of the teleradiology mode. I know that. So how do you think can the information access play a vital role in bridging the gap between the urban and rural divide? You have been a proponent of the whole telehealth mode. Over to you.
Thank you. Thank you, Mr. Devanand. And thank you, ArdorComm, Mr. Chandan and Ekta and the rest of the team for inviting me. Very interesting discussion so far. I've learned a lot already from the Eminent panel members. So thank you, Mr. Dev. I don't call myself as any pioneer in teleradiology because probably it has been there since much longer time than when I started in India, because I was the one who actually started my radiology career with the films, and I actually saw how the transition happened from the films to the digital radiology settings. So it has been quite significant journey for me personally as well as professionally. But saying that, things have certainly taken a very, very drastic turn for the better in general regarding healthcare technology, but specifically to teleradiology, telepathology, and to a certain extent telemedicine as well. So coming to my field of teleradiology, so we in our hospital report for patients across the world, especially UK, Ireland, and Australia. And I'm one of the clinical leads for a big organizations in the UK. And the technology which is currently available, which permits us to report a patient who is coming in acutely unwell in a remote hospital somewhere in Europe, and sending the scans 4,000 miles across the ocean to India, getting reported and sending back, and clinicians taking an action, all happens within 4 or 5 minutes for patients like stroke, for example. So just amazing if you can imagine how this has been carrying on since the last few years. And the added benefits of AI, which is coming over since the last 1 or 2 years, which has been propelled by COVID times, has been even, more made this space very interesting and very fascinating. And future can be very, very bright based on what I'm seeing at the moment. So what we currently do is we have an AI algorithm which triages, just like a human triaging a patient who is very unwell versus patient being very well. So it triages and highlights to us saying that this patient has got something very abnormal on their scan. So we need to look at those scans first, because a few minutes may mean a life and death matter for those patients. So once the triaging happens, it comes to us and then we get to see the reports. And I have an extension number which I can quickly call the clinicians across Europe and then get the report onto them. And we literally saw several patients being treated this way, several patients who would otherwise have a very difficult time to survive or have long-term consequences, but just getting better with all this technology in place. So in one word, it's absolutely brilliant. But let us go to the opposite side and speak from the Indian perspective. Whether this technology benefits, if so, benefits what kind of population? Are we talking about benefiting only the rich, higher class where the affordability is higher? Because certainly it adds to the cost of the healthcare system. Technology is not cheap, so we really have to take it appropriately. So not add each and every technology to what we consider as very good, but it's all a balance that we have to maintain, and to see whether the money that we pump in, the investment that we made, gives us a better quality of clinical care to the patient, B, improves patient safety, and also ultimately reduces the cost to the patient or to the insurer. I think if we don't keep all these three things as top priorities, especially the long run cost of the healthcare system, secondary to use of technology, I think things won't be so sustainable. And so that has to be always kept in mind. Thank you very much again, once again. So, yeah.
Thank you, Dr. Venkat. I think, it's look interesting, the AI algorithm that you're mentioning about triaging. We'll come back to you later with a few more queries on that. So now you have opened up a specific thing called affordability in terms of the, urban-rural healthcare divide. Affordability is a major issue, especially when the rural mass is considered. So that takes me to the next question, which I want to again go back to Ms. Ekta. See, the rural, we know that urban, the kind of healthcare that we see, the payer mix that we see in the urban healthcare is moving more towards the insured class. While you see a lot of gap in the rural areas still to adopt to that insurance, even though the Ayushman Bharat and the public health has come in to support them. But in terms of the private insurance, it's still picking up very slow. So what do you think? How can the e-health services reach this uninsured rural class? How do you think that can be achieved?
Yeah, so that is a very interesting topic when we talk, and I think I remember the saying which says that we should not cut down jungles, but the need is to irrigate the deserts. So I think this is a very untouched area wherein we never thought that how fast the internet services or the mobile data services can reach rural areas, and even rural people can get benefit on that. So even we have a question from audience also on how the small clinics can collaborate with big hospitals to serve in the specialities or super specialities which are not available in the rural areas. So nowadays many startups are coming up, and even we have collaborated with one of the startup who has developed a kiosk which we have placed in the rural clinic. The doctors who practice in the rural areas, and for any super specialist consultation, they don't have to turn here, because many times it happens that they have lost two followers. If a general physician advises for any super specialist consultation, then it's not a surety whether the patient will come over to the hospital, get the consultation, or for the illness itself. So I think this by this kiosk, which is like more over a teleconsultation. So the consultation is done, medicines are prescribed, they can get a prescription there, and even a few blood tests and like common blood, like blood sugar and even BP measurement and everything is also done. So the need of the hour is to reach them. So reaching the rural population is very important, and we need to reinforce them like usually rural people, people staying in the rural areas, they don't visit the hospital saying they lost the Mondays of their working. So minimizing the ALOS, the average length of stay in which the patient gets admitted, reinforcing them the need of the safety and everything, which is very important to cater in even Ayushman Bharat scheme. So a lot of this Ayushman Bharat schemes, people get admitted here, but due to the ALOS, they are very, very, they abscond, they don't stay, they don't follow the doctor's advice. I've been practicing in a hospital which is in the rural area, so I can relate to these very well. We have a lot of patient abscond, and the reason simply says that we cannot lose our men hour of earning. So this is what we can pitch in and how best we can get this. Of course, reinforcing the geriatric care and the Anganwadis for nutrition for pediatric population is also a very important aspect in which we should look of for when we're talking about the urban rural divide. So I think we should improve the emphasis on the surveillance. We should have the data by which we can come to and where exactly we can intervene and help the rural areas to grow up and use the urban sector too.
Thank you, Ms. Ekta. Thank you so much for that wonderful insight. So, using the public system also to support you in adopting to the technology or, or going to the masses will be a brilliant idea. Probably Ayushman Bharat will make that revolution coming in, like Jio brought the mobile revolution to India. So the government will be the starter here, and then probably private also will take off in rural. This is what I also expect to happen very soon. So I'll take the next question to Dr. Rupali. I actually handle the Andhra Telangana cluster for Aster. So Andhra was a new market to me. Recently, I was covering a portion of Andhra where I was looking at different opportunities of, getting connected to the rural Andhra. Andhra has still a lot of villages which is still doesn't have that kind of an access to healthcare. So when we were thinking of an outreach center with a telemedicine model, the major thing the team was telling me that there is a huge behavioral change in consumers that's required. People still, I think Dr. Karanjekar mentioned about it, the human touch is missing when telehealth is considered. They still feel that a doctor has to be present physically to give the care. So how can this consumer behavior could be influenced, towards the digital adoption? It's very tough, I know, but you have been working with that, so we expect some good insights from your side. Yeah.
Thanks, Dev, for the question. Yes, as you said, behavioral changes are the most difficult part because you are actually going inside the mindset of each individual, and we all are. We think differently, everybody is different, so we have our own thought processes, and when you want to change those thought processes, any change, and especially in the mindset changes, takes time, and it takes a lot of factors. So I think the low-hanging fruits, what we can do as healthcare, healthcare professionals at this point of time is that COVID has taught us a lot. It has actually pushed us to the technology front a lot. Each of our phones, actually, the moment you take a call, that it is telling you that do this. From the government also, they were giving a SMS message. You are getting a caller tune. So the process has already started. What we need to do is should not slow down on that process. We should not, we should take the advantages of what has come in, what the new things have brought in for us to connect to people. What are the tools that I have? What are the messages that I can do? How we can do it? What are the ways we can? And we have to, kind of be at work and execute those at this moment. We should not miss out any time. That's one particular point. Then the other part is that how you are going to do the communication to the person. What are the tools that you have? You have primarily, the newspapers are gone from our lives now. It's nobody reads lately. Even now, the newspapers do come into our homes too. We are very traditional newspaper readers, but it is the value of a newspaper is going down. We have a phone in our hand and we have the TVs. Or maybe probably the laptops and the computers for some people. In the rural areas, I think TV is a tool which we have, a connect, and also the mobile phone. So we have to use maximally what we can. We have to do in SMS format. We have to do caller tune format. If I look at the phone, because if it's a smartphone, then there can be, all the social medias are available there. The apps can be downloaded. You can create new things, and continuous communication in the regional vernacular languages, looking into the people's mindset, that what will work for them. That's I think the quality of communication is the next bit. What we have. The time is right. What we have in our hands is only the TVs and the phones, and TVs are very expensive when you would like to communicate, advertise, or say. So we have to use government in this a lot, because government to the rural sector will be easier for us to use. I think and we have to tell the government do this. We have to advise the government that I do communicate to government a lot. Even though I'm working in a private sector, 30 years I've been communicating. I keep writing to them. I keep, writing the right, you have to be the right language. You don't need to really, look at your own interests. It is all about creating communities, reaching out to people. So reaching out to communities and in rural areas. So you have to keep doing those kind of communication so that they put it across to the TV and use the phones which we have. And then the quality of communication is the third thing I think is very vital, because you have to reach to the mindset. So many a times we do create communications which doesn't make sense to people. you need to understand, you have to be sensitive to understand the people, and then create the communication which is will be read by and understood by the community where we are talking. So all these things I think are important. We have to keep communicating. We know that awareness generation and using technology has to be mindset change. And I think overall, when the country becomes digital, the way the government talks about digital India, and they also have, I think government has a lot of digital focus in their programs. The more the whole country rises in healthcare, the community also will rise. So there will be taking a little bit of time, because it just we can't just be very smart in one area and the other parts are not even looked up to. The food, the general health, general the way we live in the houses, the roads, everything is important. So everything improves. Connectivity improves, the roads are important, the bandwidth is important. Both improves, I think we will also reach to everyone. The dream, we should not miss out on our dreams, that we have to do quality care for every Indian. So the more if we are focused on our dreams, things will happen.
Thank you. So that's very very good insight, especially the regular quality sensitive information or communication passed on to the mass. Yes, that is definitely going to make a change. Now, my next query or question is to Dr. Karanjekar again. So, we know after COVID has come in, there is a huge focus on telehealth. And that's one vertical of the digital health which has got very high momentum in terms of the implementation. But in rural settings, we also know that, but there are a lot of other factors to the entire digital health in terms of remote monitoring devices or the IoTs that we talk about, or the data analytics, the predictive analysis, AIs. So a lot of things have come in. But what do you think, other than telehealth, is there any other digital health tool which can really fit into a rural health setting that we as a country or as entrepreneurs, are they trying to develop something which can really fit into the rural setting other than telehealth?
Thank you. I think in the rural health, I was recalling something for last few days when I last went to the bank. I don't remember. Last 2.5 years, not by Corona. But if I have to transfer money, it is within minutes. If I have to receive money, it is within minutes. I have to do something to the, even I remember I had to go to the workshops or my car servicing. At the end of the day, I have to go there by taxi, pay the money and bring back the car. No, that's not required. The link is there. He says, you pay, I will send the car. The thing is that even the vendor, the vegetable merchant, or even the small vendor says that this is my QR code, snap it, pay it. I don't have to do their money. So the question is of acceptability. People have become aware and accepted that this kind of transaction can happen. Similar acceptability when it comes to the rural area, it will be much better workout for the healthcare. Now, coming back to the, apart from e-health, what is there? See, we are talking of clouds, we are talking of satellites, which will be providing the bigger bandwidth and everything. I remember about 8 days back or 5 days back, there was a news item by Reserve Bank of India saying that they will develop a system whereby the payment will be made even if you don't have 4G or 5G. The payment system without having a proper bandwidth or not having the internet facility, still you can pay, is something remarkably different. If I have similar facility to be used in healthcare, healthcare has always been follower of science, physics, chemistry, optics, anything, IT, everybody invents and then we use it. We are the user of everything, not inventing everything. So once it is invented by accounts people or the IT people, maybe we'll follow it in our area. Whether it is gastroscopy or anything, robotics, we follow it little later. So this is one area, that is the your cloud computing and internets with the help of satellites is another area. But if I give an example, of Corona again, I had few trustees at Surat Kiran Hospital, and they were quite serious during that time. We treated the largest number probably in Gujarat and Western Maharashtra for Corona. And whenever required, I used to ask my Mumbai doctors or ICU specialists for second opinion. Either I used to airlift them or, but here the WhatsApp messaging and WhatsApp imaging of the ICU came very handy. I may not have a facility to transmit my signals and all numbers which are there on the monitor to Mumbai to recognize it. I can put it on a camera and transmit it where he can see it, enlarge it, see it, and give me an advice. Ultimately, he's going to see, even if he is physically present, he's going to see. And they have treated almost 15 to 20 patients like that. Out of that, 10 to 12 came out of that. So the thing is that even if I didn't have bandwidth, even if I doesn't have anything, on a mobile, I can take the image and transmit the image. So only internet is not the way of transmitting image, I would say. Transmitting the image are multiple ways which you should be using it. And once you use it and show it to that fellow sitting in front of you, now the technology problem like I experienced today, having been in the city like Mumbai, I experienced this problem. So in rural area, if that fellow he fails, it's a failure. So should not happen. You should have a robust system, show it to him, you show the face of the doctor, ask him to talk to him, get a feel that yes, this works. So if that is there, then it will be there. Again coming to the original point, our colleague Dr. Venkat said about the teleradiology and other thing. Yes, it has been a greatest tool. I remember in Bangalore, few years back, I had been there. There was no radiologist in the main hospital, and still they were reporting from their peripheral hospital radiology within minutes, like somebody sitting in that room. Same thing can happen. Today we do it. PET scan, CT, MRI, everything what I have got here. All rural hospitals, they send it there one and we get a report. So this modality, biochemistry modality, they are transmitted and immediately a report comes to you. But yes, these are limited to the diagnostic and consultation. Treatment-wise, very few people have adventured into doing a remote treatment. Because again, there are limitations of diagnostic tools to be available at a remote place and a medical person using them. Both things happen properly, probably we are. But I'm very sure that we are on the way of progress, and either it will take 5 years or 10 years. By the time we will be reaching every nook and corner of big city and also the surrounding area. Gradually, we'll go to the smaller cities also. So multiple tools can be used, multiple probably adaptable instruments can be used for this purpose, which will give us the thing, and then later on even treatment modalities can be also useful to us.
Thank you, sir. Thank you so much. I think very nicely you put it, and I think all this combination of tools in terms of the pharmacy delivery, the diagnostics, the teleradiology can be mixed with the telehealth and probably go deeper into the treatment modalities. What you're saying, I think that definitely is going to come up very soon in our country also. So that is very evident from the fact that the recent budget has clearly focused on the adoption of digital healthcare across the country. So that is the next question to the panelist, Mr. Yateesh, and this is something which the country has brought in, like the United Health Interface. This is something which they have, the NHA has proposed now to bring in the digital health across the country. So what do you think, how the UHI, which is the United Health Interface, is going to help us in getting the digital healthcare ecosystem across the country?
Well, Dave, getting all your data parameters, everything online will be beneficial in the long run. If you see, unlike the West, India still today, there's still, less than 20% penetration of healthcare insurance. Now, with the digitization of records, with a larger base being made available, you would have healthcare costs going down, a larger base getting insured. Ayushman Bharat also has brought in a significant population that's been covered today. But unfortunately, there's still a huge chunk which is in between the private insurers and who are not really BPL or EWS. So with this spectrum getting enhanced, I think there's a scope for a lot of rationalization. And data mining will sort of really assist in the long term. I don't think anyone sort of has as diverse a population as in India, where even the disease pattern changes from district to district and city to city, where you've got a place like the cancer train running between Punjab and Rajasthan, wherein because of a certain topography in Punjab, you have very high cancer incidence rates. Or for Mathura, where we run one of our facilities, Agra Mathura, where because of eating habits, you have, or practices, general practices, you have very high cervical and oral cancer rates. So with a unified registry, a UHI of sorts, the data repository coming into force, it will aid the process of decision making. It will aid and take forward the journey of medical technology, the use of IoTs, which has just begun. We've not even seen and hit the tip of the iceberg. There's tremendous scope and opportunity that is available today, Dave. Yeah, Dave.
Yeah. Thank you so much. I think you covered a very valid area with the proper insight. So I think we will look forward for the proper implementation of the UHI in India very soon. So I now take it to Dr. Venkat. Probably we have to close the session. We are almost come to the end of the session. We had a lot of questions because this panel also is very, very very esteemed, and the subject is also so exhaustive. But I think we have a time constraint here. So I go to Dr. Venkat with the last question, which is, how do you think can technology be leveraged to increase the awareness? Behavior is something which Dr. Rupali already mentioned. So I want to understand how can we improve the awareness of the technology among the rural class? Any suggestions from your side, Dr. Venkat?
Okay. Awareness of technology, presume it's in relation to the healthcare, right? Because a lot of mobile phone usage has come for digital payments. So in that sense, the healthcare can be extrapolated on the same lines with the usage and the penetration of mobile phones. So again, we are seeing a lot of telehealth being developed on the same platform, using mobile health technology. Doctors sitting in a conference hall, then trying to discuss patients or even surgeries being performed remotely, for example. So all this has been happening. The exciting times are when the insurance people will take this aspect very seriously, because unless our rural populations are insured either privately or with the government, now that Ayushman Bharat is coming up, so unless this happens, and unless that also integrates some technology into that aspect, it's very difficult to really see it going in a proper direction. Because what is happening is, especially in the rural healthcare sector, tertiary care is given a lot of importance. So when a patient has a heart attack or when a patient has cancer, they can get diagnosed. They have limited facilities for treatment, etc., and they may have to come to the big city centers to get their treatment. Essentially, primary care has been non-existent, and this is where technology can actually bridge that gap. Because unless we have a robust primary care, which can be to a large extent taken care of by providing physicians on telehealth platforms, regular blood checkups, basics, etc. Unless that happens, it's very difficult for primary care to go into
I think Dr. Venkat Chandan is giving us a red flag. I think we are the time is up. Sorry, we would be very eager to hear you, but then I'm sorry to interrupt, and
no worries
apologies for this intrusion. I think we have a time frame given. I think we have to close it. So, Mr. Chandan, just one thing. I just want to take one question from the audience, which is the PPP model that they were talking about in lowering the urban-rural divide. Just one example I want to give in my place where I used to work in Wayanad. We used to work with the government to take up the rural population, especially the tribal population pregnancies. That's where the government and our hospital partnered together, where we used to provide a free treatment for all the tribal women at our hospital, but all the support till they come for the pregnancy to the hospital is covered by the government at their home, using the Anganwadi workers or the healthcare workers that Ms. Ekta was also mentioning. They will also drop the patient at our place through their ambulance, while treatment is given free from our side. They take back the patient to their home and follow up with them. So it has worked wonderfully well. We could reduce the mortality that used to be present in that district, especially it came in big news and all before we took over that challenge. Tribal women had given birth on the way and unfortunately succumbed. That was a big news, national news. And with our intervention, we could, bring it to a zero level. That's something which we could do. So PPP has an effective role in bridging that gap, urban-rural divide. So thanks to all panelists for a wonderful session. I feel that, we still have a lot of questions to answer and a lot more things to come back from your side. But I think there are, the next panel is already ready. So I think we should hear it from them. I think Mr. Chandan, thanks for once again for organizing this wonderful panel. Thank you.
Thank you, Chandan. Thank you, Devanand, Rupali, and other team. Thank you very much.
Thanks, everyone.
Please stay tuned with us, sir. Thank you so much. Lovely moderation, Devanandji. In fact, see the kind of topics which we have we have taken has given a lot of effort in research, and then we have finalized this topic, and then bringing the right stakeholders for the right panel, including. So we want to make this entire healthcare and wellness segment. We want to give every bit part in equal importance. Let it be Ayush, let it be pharma, let it be maybe a wellness community.